From theheart.org, Medscape Cardiology, this is the Bob Harrington Show. Dr. Robert Harrington is the Stephen and Suzanne Weiss Dean of Weill Cornell Medicine and Provost for Medical Affairs of Cornell University. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, this is Bob Harrington from Weill Cornell Medicine in New York City. I'm here at ACC 26 in New Orleans, and wow, what a buzz this meeting already has. Just came out of the late-breaking clinical trials section. We're not going to talk about late-breaking clinical trials right now, but I always love to use these meetings as an opportunity to catch up with friends and colleagues to pick their brains a bit on some of the topics that I know they've been thinking about, and in this particular guest's case has been writing about, to really help all of us. The topic for today is going to be trust in medicine, trust in healthcare, maybe broadly trust in society. And I have a great guest to join me here today. I'm with Dr. Lisa Rosenbaum. Lisa is a cardiologist at Beth Israel Lahey in Boston. She is the writer in residence for the Smith Center, and she is an assistant professor of medicine at Harvard Medical School, and she is a national correspondent for the New England Journal of Medicine. That's a lot. First, welcome. Thanks for doing this. As I was getting ready to tape this, I was checking out Medscape AI, and so I asked them about you, and it gave that bio I just gave of you. That's where I got it.
Okay, it's totally correct.
We're going to move into a serious topic. There is some fun things I suspect we'll get to, but it's a really serious topic, and I know you've been thinking about this. Trust in medicine. I've been a doctor a long time. It seems as though trust is declining in us as a profession. But like a lot of times when you ask about a profession, if you then drill down and ask about an individual, it's different. So if you ask, do you trust medicine? Do you trust science? The answer is now frequently no. If you ask, do you trust your doctor? The answer is most frequently yes. So let's start with the societal ask.
This is a topic, obviously, that I've thought about a lot. And even though we're talking about it a lot right now in the context of declining trust, not just in medicine, but in other institutions like media and government, I actually came to it when I was still in training because I was doing some work about why patients don't take their medications after they have MIs. And I was working with a group of behavioral scientists who were doing an RCT, trying to get patients to take their meds by sort of nudging them essentially. Mm-hmm. And I did some qualitative work.
Really popular way, particularly with devices, et cetera, to actually study behaviors.
Exactly. Yeah. In fact, my ostensible role was to make sure people could open the pill bottle that had a glow cap to tell us whether or not they took the pill. But I took the opportunity to talk to people who'd had an MI, which is funny that that's a luxury. You would think as a doctor, that's something that we actually get to do, but it turns out not so much. So 30 people who'd had an MI. We know that half of patients stopped taking their meds within a year. And people have really complex feelings about taking medications. And that was really eye-opening for me. That was 2012-ish. And one thing you would hear all the time is that people will just say, well, I forgot to take my meds. And I'll never forget, there is a professor at Brown, and I was talking to him about non-adherence, and he said to me, would you ever forget to pick up your child from school? And I was like, I don't have a child, but no, if I did. And he's like, well, the way we talk about forgetting, we say it because it's a way to frame something else that we don't really understand. And I think something very similar is going on with trust. It's become this blanket term of something where people have some friction with us as an institution of medicine. Clearly, that friction exists all across society. But I think it's this really complex set of behaviors. And it came to the fore during COVID, of course, because people didn't want to take vaccines, or they didn't want to wear masks, or they didn't want to isolate. And so we were all affected by other people's behaviors. But when I, again, go back into my own career and my own beginning to become interested in this, I realized this isn't really new.
This has been going on.
Yeah.
So let's unpack a little bit, but let's go back to this notion of I forgot to take my medicines half the time.
Yes.
And as you peeled it back, I mean, I think about saying forgetting, but it's also, as a patient, I have agency when I choose not to do something.
Exactly.
And that's really important to patients.
It is so important. I'm so glad you said that. I think if there was one singular finding in that work, it was that desire for control. And the irony about it all is that we've done incredible work as a profession in cardiology to tell people, to educate them about how empowered they are to prevent cardiovascular disease. The unfortunate corollary of that is that when they get it, they feel like they're at fault. And so taking a med feels like a cop-out. Whereas
interesting.
Yes, if they say like, I did it to myself, now I need to undo it.
Yeah.
I think it's a way to take back control. So that was one of the interesting findings.
That is interesting. And is there any common demographic or social or cultural link about people who stop taking medicines after a heart attack and those who continue to take it?
First of all, just to be clear, I interviewed 30 people. So
okay,
it's not, I'm not in your realm of like mega trials. So I'm really good.
Usually if it's less than 1,000, I don't consider it a real trial.
It wasn't a real trial. It was like me actually being a journalist pretending to
but
be
you
a
do.
researcher.
I think of it as qualitative
Yes,
research.
It was qualitative research. So not that I could find, but I will say the backdrop to all of this also was this idea that, well, it's people aren't taking them because they're too expensive. And then there was that trial that was published in the New England Journal called Am I Free, where they essentially gave everybody their meds for free and there were no different outcomes. So I think that really sort of leveled the playing field in terms of like the typical things that we think about that are affecting people's choices are maybe not what we assume. And then if you fast forward now, however many years, close to a decade, we're seeing in a lot of probably well-educated, wealthier demographics, people who have more access to knowledge, sort of more access to how science works. They often use those tools to undermine science in some ways.
So let's talk about this. The question about more access to knowledge, I would actually say just they have more access to information,
right,
but it's not necessarily knowledge.
Such a good point.
And my sense is that as people have, immediate access to things, I mean, you and I could sit here on our phones and look up a lot of different things. There's this notion, and maybe they're tied together, that we don't need expertise. I'm an expert.
Right.
You're an expert.
Right.
My grandmother's an expert.
Right.
Everybody is an expert, and it really has diminished the authority of the medical profession to make recommendations that people say, okay, I'm going to do that.
Right. I absolutely agree with that. Although I do wonder, again, there's just this extreme like range of granularity. So I don't know what it's like for you. I think you attend on like 4 North now, right? I mean, I'm a
consulting.
Yes.
I'm a consulting cardiologist. Yes.
So by definition, when a team calls you, I suspect they want your expertise, right?
They do.
So that's different than a patient. It's a team. But I, as a cardiology consultant too, I find when I walk in the room, they say, the patient says, we've been waiting all day to hear what you have to say.
Yeah.
So that the first bucket, I think, is that when people are sick, they want our expertise. And I have yet to have an encounter with a patient who says, well, AI says this and you're saying something different, so you must be wrong. More often it's, okay, well, I read, they'll often say something like, I'm really good at my own research and reading the literature, and I saw all these things. What do you think? So I have yet to experience that, the sort of very overt, like, you're saying something different and I don't trust you.
Yeah, as you know, I practiced in Silicon Valley for a long time before moving to New York. And one of the things I loved about Silicon Valley was that people showed up all the time with, at the time, printouts. Now they just show me their phone.
Yeah.
But printouts to say, hey, I read this article, or I Googled this and this came up. There were a few times, particularly, in our world, statins remain an area where people say, hey, I get it. My cholesterol's high. I'm at risk for myocardial infarction or heart attacks, but I'm not taking statins. I read too many negative things about it. And I can pull out, the hundreds of thousands of patients in the meta-analyses that show that these are incredibly safe drugs, almost 40 years of experience with them, and it doesn't do the trick.
Right. I mean, and I guess that's part of what I'm trying to get at. So like maybe you get called because a patient's having a type 2 and STEMI, right, on the oncology service. That's a very different question than I'm going to put this thing into my body every single day that I read has a small chance of helping me and might hurt me. And I think statins are like, they sit at the convergence of everything.
They really do, which is amazing to me that after all these years, all the trials, all the data, that they still sit at that nexus.
I know. But that's why partly they're so interesting, right? Because they're so good. I think they should be in the water.
Right.
I really do. And yet the natural thing, they hit the like self-optimization, biohacking, life hacking, all of those trends, and also these people who pay a lot of attention. And by the way, there are a lot of people in medicine who probably would agree with this idea that the benefit of primary prevention is small. They would argue. And
for an individual, it is.
Yes.
For the population,
it's large.
It's pretty big.
Well, but okay, so let's talk about that then. The question about the individual versus the population, I think, is also at the heart of some of what we're talking about, because you're asking people, and we are all like scripted by human nature, to buy into something that we're saying to them, it might not help you, but it will help 10,000 of you.
Yeah.
And we're trained to think like that, but most people aren't.
No, most people think about, what does it do for me?
Exactly.
Yeah.
And that's very human.
Yeah.
And so I think again, when we say, well, is there distrust, or are people more empowered to express these human things that they've always felt?
So is it, with more ready access to data and information from a variety of sources, is that just giving people the tools to ask more questions? And trust is a component of it, but lack of trust or losing trust is not such a new thing. It's that people have more tools, to go back to my original phrase, give them agency.
Exactly. It's like they have a new language.
Yeah.
We democratized information. Everyone's on the internet.
Which is great.
Yes, mostly. I mean, it's great depending on, where you sit in all of this. I still think it's great because I think philosophically, like, I see my role as a physician and as a writer, like, I want to help people live their best lives.
Yeah,
and
longer, healthier. It's the AHA model, right?
Yeah.
We want people to live longer, healthier lives.
Yes, and part of that, though, if you're putting a statin into your body every day, and something about it makes you, I'm not even saying makes you feel physically bad. It's not a muscle problem or anything. It's like something psychologically bad. Well, that counts for something too, And so, to get back to this question of trust, I do think there are some clear changes, like, that we can't ignore, like social media, AI, pandemic, like public health, whatever happened.
Public figures who are saying you shouldn't trust us. People who have vilified, organizations that promote healthy living.
Right.
And there's a group out there that's promoting, no, those people aren't right. Those people are bad. They're giving you bad information.
That factor, I can't quantify it, but it's like undoubtedly contributing to all of this. And I think it's also part, again, of our tribal political milieu, that everything has become sport in a sense, but not in the fun way, in the tribal way. And science has now fallen into that trap. But again, I think that a lot of what we're seeing is that people, like you said, have agency. They've found some agency and tools to express things that they might have been feeling for some time.
So when you think about trust, and we talked about it, there's the trust of the profession, then there's trust of the individual. There does seem to be more trust in the individual, particularly if you have a relationship. You make rounds in the hospital, you haven't quite established enough of a relationship to have total trust. But if somebody's been seeing you in the office for, let's call it 10 years, there tends to be more of a personal relationship and they trust you.
If there's like one thing we could actually do, if we agreed upon a definition of trust and said we need to do something, it would be to give everybody a primary care doctor and let them have time to have a relationship with that doctor. So
I've spent time reading your primary care series in the New England Journal, fabulous series on primary care.
Thank you.
It's something that now, running a medical school, that I think about all the time. It's, not to diverge too much, but if you ask young people when they show up in medical school, their career options, I almost guarantee that primary care will be on the list. When they leave medical school, it's very infrequently on the list, particularly at a place that stresses, research, et cetera.
Right.
And we've got to really rethink this. And I've been reading your series and trying to ask my education team, how do we rethink this? Because it should be a much more interesting field and a better compensated field than it currently is.
I totally agree. I'd love to talk to your education team. I would love to help think about, you could start where you are because you can do whatever you want because you're dean.
Thousands of faculty wouldn't say the same.
I know. But okay, let's just pretend. But like, what if you created a curriculum that then others could follow, but where we thought about primary care differently, where we just began at a very different place. And we brought back that notion of like the consummate doctor.
Of trust.
Yes. And that, really think about all the forces that they're facing in terms of AI and isolation and like a just general sense that people are spending their whole lives like on the internet and lost and nihilistic, really. And then said, well, there's this role that you could do where you don't just get to take care of people's diseases and their chronic diseases. You get to really like do something very tangible to address this sense of pessimism that is plaguing all of your peers. Like that would be a very different pitch.
It makes me think about this notion of the concierge physician, which has become wildly popular. And I think it's in part because there is the relationship trust piece that now can be built because now you're taking care of 200 people, not 2,500, which is the typical panel size for a primary care doc. And I think it's allowing both sides, patient and physician, to recapture some of the magic of the relationship.
I absolutely think that that's why people are doing it. And I wrote about concierge medicine too. And when you talk to the physicians, like they're so happy.
Yeah.
They're so happy. And it's, we have to acknowledge it's bad. It's bad for inequities.
I said the same thing at my place. I said, I don't mind having concierge medicine as long as you can assure me that we haven't abandoned health equity and that and that the poorest person, most vulnerable person in our system is going to get great care.
Right.
And if you can assure me that along that spectrum.
Right.
But it's tough.
It's really tough. And like the only way I could think about approaching it in a way that acknowledged the happiness. And it's funny because you began with agency, and I think physicians having agency is as important as we're all human. We're all responding to the same need. But when I wrote the piece about concierge medicine, the question I had faced was, okay, the inequities are obvious. It's like a math problem. You don't need me. You don't need me to do math. But
you don't need thousands of subjects to work this one out.
No. But like, what can we learn? What are they reacting to within traditional medicine, and what are they bringing to their practices? With the broader question being, can we bring some of that back into traditional medicine? And again, when you think about designing a curriculum, I think that would be a really interesting piece. Let them go into shadow concierge practices.
Yeah.
What are they doing? What are the elements of care? And then what's been really heartwarming to me, in putting together this podcast, which has been about so many things in primary care. When you talk to people at FQHCs, for instance, or a lot of docs in primary care who have really they have just come out in spades to remind me that there are actually a lot of happy primary care doctors. They find agency in their own ways, and it's quiet. And there's this interesting tension in how do we recognize that they're happy and they're doing this very meaningful thing quietly without destroying that quiet joy by talking about it? Do you know what I mean?
Well, the FQHC thing is a really important one. You talk to those docs, really committed.
Yep.
Really believe that they're doing important work, really care deeply about the social mission.
Yes.
And they are happy.
They are happy.
They're working their butts off.
They work their butts off. Yes.
But they're very happy.
Yes.
And they're frustrated by inequities in the system. They're frustrated by, just a lot of the federal funding issues, the state funding issues for Medicaid, et cetera. But they do find joy in practice.
It would be really cool to have students see
all of it.
See all of it. Yeah. But again, I think trust has lost its scale, but it is built one person at a time. And I think it can only be built in the context of relationships. I don't think it exists as this abstract concept. It's the same as the forgetting thing. It's okay, it's something I can vaguely understand, but what does it really mean?
We can't have a conversation about trust without having mentioned the pandemic.
Right.
Boy, we lost a lot of trust with the public. One of the things that would always surprise me, including with my very well-educated friends, we'd be on the phone regularly. I'm catching people up. Hey, this is what we're learning. They said, but last week you told me something different. And for me, it's well, that's just science. In the last week, these 2 papers came out and now we're going to do it this way. Yeah, but last week you told me something else. Was that part of it that you and I and our listeners understand the scientific process. You do an experiment, you learn, you go forward, you adapt, you test it again, you learn something different.
Right. I don't know. And the reason I don't know is because I feel like people make up their mind about something and then they find a way to reason toward it.
Which is the opposite of the scientific
process, right. So I can't tell how much of that sort of backwards logic, because, you know, we would hear things like, you didn't admit uncertainty. Well, but some people will say, well, when you say you're uncertain about something, then, so how much of this is just that people have a gut feeling and then they find ways to poke holes in what we're doing? I also want to be a little bit like soft on how I feel about this, is because I don't think the answer is to stop changing our minds when we have new data.
Keep doing science.
Yeah, exactly. Like the one thing we can do is keep doing science. And I don't know. There's so many forces shaping people's impressions about things.
Yeah.
And that I just don't know what really fueled the disbelief.
Well, the other thing for me with the trust has been this long time, what I'll call problem of the separation of public health from medical care.
Right.
And you go back and you read the original documents around Flexner and the adoption of the scientific method. And then you read the formation of public health, you know, several decades later. It's really in a reaction to some of the, you know, medical care issues that they're trying to address. But boy, there's a separation there that's also made it difficult.
That is so true and unexplored in our discussion about this. It's something that I've been thinking about a lot, because I think when we talk about trust, so often it's about vaccines. Vaccines are obviously important, but they're just like such a small part of this. Again, to go back to this idea about cardiovascular disease and people not taking their meds, and like that's probably affects like more people, right? But it's become this problem that's centered in public health, and public health has a very different set of tools than we have, and they don't get to have the relationship.
It's not a one-on-one thing.
No.
Yeah.
So I think that's a very interesting observation, and one that I want to explore more.
If you talk to colleagues at medical schools that are also part of a university with a public health school, often the two shall never meet.
There's a public health school at Harvard. I mean, I have some friends there, but it's not like we're in dialogue.
And it's not like our students are constantly, you know, crossing the boundaries, et cetera. So it's always been interesting to me that why can't we get those closer together? And after the pandemic, it would seem we got to get these closer together, because one of the real failings of the pandemics was the failing of the public health system.
But I don't think that's going to happen imminently.
Yeah, but believe me, and I have a lot of things to tackle.
Yeah. But I mean, to get back to like your role and where you and I both sit in the House of Medicine, I think there is tremendous opportunity, especially right now, to bring back relationships.
And to foster trust through the building of relationships.
Exactly. I think people in society want it, the students want it, and we need to show them what that looks like. And the saddest thing would be if we become so fragmented and also disillusioned ourselves that we don't show them anymore.
That's a great comment, because as I think a lot about the training of young doctors, and this is a key component, is that how do we teach them in a world that's information is immediately available? We had the AI, talk a few minutes ago, and they've got all that information. What makes what they do special?
Yeah.
I refer to my colleague, Abraham Verghese, that we're in that long tradition of learned intermediaries.
Right.
And that part of what we do is we build relationships. He likes to call it being present, and that we're present. People know we're there for them. We have information that we should be learned interpreters of that information, but we can only do that if people trust us.
Not only do I completely agree with that, but I think also if we are doing our jobs well, I mean, we all want to feel special. And there is always going to be a need for that human to human. Algorithms are great to a point, but there's always that soft touch of expertise, which is about judgment. It's about knowing somebody. It's actually an extreme form of intelligence that I think we need to really focus on as well.
It's funny you say that. I was meeting with one of our deans of artificial intelligence. He's a computer scientist, informatician, and he said to me, well, I was writing some code. And I said, well, wait a minute. I thought we didn't have to write code anymore, that the machine writes it for us. And he smiled and he said just what you said. He said, that's fine for a couple of lines of code.
Yeah.
But as it gets more complicated, there's still a need for expertise.
Yeah.
And the way that he, as a computer scientist, asks the machine to write something is different than the way I might ask. And then we extended it into medical care. Yeah, you can ask the algorithm, how do you take care of, disease XYZ? But there's still a need for expertise.
Exactly.
And I go back to the early days of the early writings of Dave Sackett with evidence-based medicine that gets a lot of criticism for cookbook, etc. But that's not what he said. He said evidence-based medicine is using the best quantitative information available, coupled with expert wisdom and judgment, and put into the context of that patient's values and preferences. And that, to me, sums it up. That's what we're trying to do.
Maybe AI will force us to be more clear about what we mean by expertise.
Yes.
Because we all want to feel needed in this world, and we are going to be pushed to recognize that layer where we come in and only we can come in.
You see it when a doctor asks a question of an algorithm, and when a layperson asks. A layperson can go down a weird path because maybe they didn't get a word quite right, or they brought in a mistake. But when you ask about something in cardiology, you're asking it from the position of a cardiologist.
Right.
You get different answers.
You get very different answers. And the algorithms kind of give me a headache.
That's a good place. We're going to end it on that. I want to thank you for joining me.
Thank you so much. It's so fun. It's my favorite stuff to talk about.
My guest has been my friend Lisa Rosenbaum, who is a cardiologist. She is the national correspondent for New England Journal. She's at the Smith Center, at the Beth Israel Deaconess. She does a lot. And I'm really happy that she was here to talk to us about this subject of trust in medicine, trust with doctors, trust in public health. And I suspect this is a show and a topic that we'll continue to come back to in the year ahead. Thanks for joining us.
Thank you.
And if you liked it, give us a thumbs up. More importantly, if you think we can improve, let us know what we can do to improve. We're here really to serve our listeners and our viewers. And so let us know what we can do to make the show better. Thank you.